The Geneva Sustainability Center is here to support hospital and healthcare leadership to ensure their contribution towards a healthy and sustainable future. You might say a few words about that. And you come, Sonia, with 30 years of experience in health and social care internationally as clinician, senior hospital management, and in sustainability. Previously, you were International Climate Policy Director at Healthcare Without Harm and Director of the Sustainable Development Unit of the NHS in England. Very inspiring work for us. So over to you, Sonia. Have a good panel.
Very much, and welcome back, everybody. I'm really looking forward to this panel. We've got lots of great discussion to be had, and we are joined by 2 people online, and we've got 3 people here in the audience. I'm really hoping that we're going to get all of you participating as well, because we've got some experts here, but we would like to hear from you as well, and make sure that you join in with some key questions. So yes, I'm Sonia Roshnik, and I work for the Geneva Sustainability Center, and our key focus really is to recognize hospital leaders have got a real role in their leadership role to integrate sustainability into everything they do. It's just part and parcel of what contemporary leadership should be about, how you deal with emerging problems, climate change, how you decarbonize your facilities, how you build better resilience and better care, mostly because I've got this fundamental belief, and maybe because I've been a clinician and a manager and all the rest of healthcare, but this is about health. It's not just about the environment. This is fundamentally about all of our health. And so we really have to be thinking about how we take this forward. And so there's a real role for healthcare to do this systematically and aggressively, because it's a matter of urgency for all of us. But I think the interest that we've got with the panel today is that we're going to be looking at what this means in low to middle income countries, where actually the challenge is, how do we really deliver, good access to healthcare that is low carbon, that is resilient, and that is equitable? And my dream, I hope you'll share this dream, is that by using the climate change and the sustainability lever, we might be able to seriously transform our health services for the better and our health systems, and actually provide systems that deliver better health, not just a sickness service. And that is the challenge that is ahead of us all. But I'm delighted that we've got a fantastic panel today. We've got Dr. Jemilah Mahmood, who's joining us from Malaysia. We've got Dr. Fawzia Rasheed, who's just arrived in Geneva from the Aga Khan Foundation. We've got Kiran Jobanputra, who's based in London mostly and works for the Climate Action Accelerator. We've got Aditya Gurundati, who's from Dr. Reddy's Laboratories and joining us online, and then Vincent Bretin from the unit. I'll introduce them more each in turn, and we've got some key questions for them. So Dr. Jemilah Mahmood is the Executive Director of Sunway Centre for Planetary Health. She's a medical professional with decades of experience managing crises in health, disasters, and conflict settings. And so, she's a professor and executive director, and really talks with inspiration about what this means in a country like Malaysia to really transform our healthcare. So, Dr. Jemilah, thank you so much for joining us. I would wonder if you could tell us a little bit more about what you feel the needs of populations are around this, especially those that are more vulnerable, and how we can support them with some more resilient and sustainable approaches. And maybe if you've got 1 or 2 examples that you can sort of feed in there as you go along, we'd be very grateful. So over to you. Thank you.
Thank you very much. A real pleasure to join all of you. Speaking from the perspective of someone who's actually living in Southeast Asia right now, you will be pleasantly surprised to know that if you speak to leaders in the region, they will voluntarily tell you that climate change is a real problem, but they don't voluntarily tell you that the health system is one that you need to look at very, very closely. So, it's still something we have to work very hard on, linking the climate crisis with health as a health crisis as well. So I guess in terms of what is actually needed, a lot. First of all, I think the clarity and the links between climate and health needs to be there's a lot more work we need to do on that front in advocacy, getting people to understand that very close link. And, although most of the governments and the actors in the region are fully aware and supportive of universal healthcare, we do have, I feel, a lot of work there. And the other thing, of course, is that as a region, this region is rapidly growing in terms of economy, and with it comes, other challenges as well. So it's not just climate change; it's got, issues around development, planetary damage, dietary habits, and so forth. But if I can stick to some kind of concrete things that are being done, first of all, let me speak from policy angle. If I speak from perspective of Malaysia, we are in the process of actually looking at health transformation and really focusing on wellness, and therefore the climate crisis has been something we are working very hard on, pushing the government to say you've got to include this as you look into health reform. Secondly, in Malaysia, we are embarking on what I believe could be the first national planetary health action plan, which is really bringing policy thinking around a multi-system shift to look at how societies will thrive in the face of planetary changes and the climate crisis as well. Now, one of the things that is being leveraged on a lot, obviously, is technology. So telemedicine and e-health, needless to say, countries like Singapore are using this a lot. Even in Malaysia, we're looking at it from perspective, not just giving access to people, but also reducing the need for them to travel and ultimately the carbon footprint, which has impact on the climate crisis as well. Otherwise, it's really also looking at how community-based approaches are used. Two nice examples which I like anyway. One is looking at a situation in Kalimantan, where an NGO called ASRI is looking at the needs of people in communities who tend to embark on deforestation activities, primarily because they want access to health. So giving them healthcare and giving them healthcare instead of machetes to chop trees, really giving them alternatives to economies and livelihood is one way that you access health, but also protect the environment and also reduce the impact of climate change. And of course, in places like Philippines, which are very climate resilient, climate risk, they need to really step up on climate resilient health facilities, and this is one of the primary focus areas for countries like Philippines. I could go on, but needless. What I want to emphasize is the awareness is there, trying to bring greater awareness to health systems strengthening, and resilience is what is really needed. So I think it's not just about action on the ground. How do we actually start moving policy dialogue? And at the ASEAN region, ASEAN is now looking, as it embarks on the next 10-year strategy, on something that is looking at sustainable resilience. And it's a huge opportunity now to influence that from a health lens.
That you're looking at this very much from a systems perspective, and that the end goal is really about how we can all thrive in these conditions. So that's a very hopeful vision that we can all be working towards. So thank you, and please stay with us because we'll come back to you as well. I'd like to turn to Dr. Fawzia Rasheed, who works for Aga Khan Foundation as a health advisor. I know you've been working on this for such a long time with the Aga Khan, and how you can really demonstrate that this is possible in all sorts of different places and that it can save money. So I'd love you to tell us a little bit more about what you're doing and why this is so relevant.
Well, thanks very much. But firstly, I should say not foundation, but it doesn't really matter. Development network or health services. Yeah, there are a couple of things, messaging I want to get into this in terms of, in addition to relaying, our experience. One is that, when we started, health professionals were generally concerned, but really not really thinking it was their business to get engaged. And the other is that if they were engaging, they were tinkering around the edges, doing things like planting trees or changing their bottled water, and really not making intelligent priority decisions about what they could do with their agency, which is enormous, not just in the health sector, but they could use their political clout, their leverage, they're part of the political elite in all of our countries to make transformational change if they knew what to argue for in the transport sector, in the energy sector, in the agricultural sector, which is incidentally not irrelevant to health, as well as the health sector's performance, because the health sector intersects with all of these areas. So I'm just sort of bringing that up sort of into focus at the beginning, because these were things that I faced when I started to do the work. But basically, our story is, I'll try and just capture it very quickly. We have facilities in the likes of Afghanistan, Syria's, Pakistan's, and so on of this world. And basically, I mentioned that at the outset, because if we can do this, anyone can. So at the beginning, where I think this, going back to my sort of opening remarks, where I think you can make a real change is by doing what we did, but we didn't do it for those reasons, but by collecting your data. Because once you have your data, you then see what is possible. You then see what it costs. You then see what it might save you. You then start to rethink where you put your energy in terms of what you can make changes against. And you begin to see the bigger picture in terms of no point my tinkering around with my waste here when the municipality is doing that there. Or if I do my solar panels on all of my 5 facilities, well, actually, wouldn't it be better if the national grid started to make some efforts in terms of transition to renewables? So that kind of thinking is something that I've witnessed along the way. But back to our story. We started to collect the data by developing a tool with the best of scientific advice and doing it ourselves. And we made it so simple that it was possible to do within our health facilities, no extra staff, no consultants. And I knew that that was the way to go if we were to do it, not just in our countries, but because this wasn't an endeavor where you started with a baseline and stopped there. You had to keep measuring to see what progress you were making. And happily, our agency and our governance also relayed the challenge to all, people, the likes of myself, but also the schools in the Aga Khan Development Network, the insurance companies, the hotels, poverty alleviation, habitat, agriculture endeavors, all to get to net zero by, if not before 2030. So we were running from the beginning. And I honestly think, back to that comment, it is not stupid to set that target because we're seeing that we can do it. If you don't set that target, I've just, on reflection, if you set a 2050 target for yourselves, I mean, seriously, I'm going to retire in 5 years. What does that mean for me? Not a lot. So 2030 was our target. We developed our tool, got it endorsed by WHO, and our tool expanded to cover the supply chain. Very important for the health sector, because without it, you're not measuring your impact. Believe you me, you're just kidding yourself if you're not. So we made it free, translated it, and of course, we knew then that people would be knocking on the door to get some help, and we've provided free orientation to representatives of over 40 countries while doing the work ourselves to carry on going. The tool was the first, if you like, learning and gift. But since then, with our own data, and we collect quarterly from 400 facilities, 400 facilities, every quarter bottom-up data. So if we can do it, you can do it. What we found is that when we tried to look at the very simple measures, just in terms of energy efficient equipment and transitions to renewables, we could come up with a budget that would cover 60% of our footprint reduction, 60, and we would get a reduction, a return on investment less than 6 years. And in fact, at today's prices, if I recalculate, it would be about 4. So imagine that. We immediately saw that we had this sweet spot space to do things that would save money, reduce carbon, but also, hey presto, all of these measures mean that you consume less. Therefore, you're going to be more resilient in the future. And if you transition to renewables, flood, heat wave, electricity outings with extreme weather, you're going to be able to keep going. So, this is not just a mitigation agenda. Decarbonation should be understood to also be an adaptation and resilience measure. And let's get rid of this dichotomy because that's not helping. Now, if I might just finish with frustrations. I can't believe that with us showing this, that it saves money, that there are things you can get along with, and that if LMICs don't engage with, they will be left with more expensive and dirtier and unsustainable healthcare. That there's still this talk about high-income countries should do this, and we should, LMICs, too technically difficult, too expensive. That's rubbish. So I'm beginning to think that donors, agencies who are in this, the UN agencies who are supposed to advise, simply haven't done the math. And I would suggest that the very best place for everyone to get started, and you have no credibility in this field if you don't, is have your own baseline, set your own net zero targets and get on with it. Because if you can't walk the talk, you shouldn't be in the business. Thank you.
Thank you so much. So a serious challenge to all of us. Thank you. So, measure, set your target. And I'd like to say about setting targets, because I agree with you, you need to set them closer rather than far away. And actually, generally, they keep getting closer and closer as we see that the urgency grows. So we're going to have to work with that. So the more we can demonstrate it, the better. So thank you so much for that. I'd like to turn to Kiran Jobonputra today, who works as a doctor, medical doctor, a GP in London, but you've also been sort of the head of the health programs for the Climate Action Accelerator. And I know you've been doing this huge sort of very on the ground project in Chad, which has really been quite interesting and brought out a whole load of new lessons. I wonder if you can tell us a little bit more about it and what it says, what you feel that it's telling us to do.
Yes, thank you, Sonia. So, well, thank you for the invitation to join the panel today. As Sonia says, I'd like to share a few lessons from our experiences of working with a hospital in Chad in partnership with ALIMA, the International Medical NGO, to look at transitioning this hospital to a climate resilient, environmentally sustainable healthcare facility. It's fairly early days in the project, but the process that we undertook, the vulnerability capacity assessment that we undertook together with the hospital, did yield some insights that I think are quite instructive for this discussion. We made the decision explicitly to focus on healthcare facilities in fragile conflict-affected and vulnerable settings in the first instance, partly because there are increasingly toolkits and models for healthcare facilities to transition in high and middle income settings, but we found a lack of worked through models in low income and fragile settings. And the WHO guidelines were our starting point for this, the climate resilient environmental sustainable healthcare facility guidelines, and also the checklists for vulnerability capacity assessments. But very quickly, we realized that these tools need a huge amount of configuration to the setting to be operationalizable. So the hospital that we're working with, Nguri Hospital, is a Ministry of Health hospital supported by two NGOs, ALIMA and Alert Santé. And they shared this vision about transitioning to a climate resilient, environmentally sustainable hospital. We set up a team to make this happen. And the first step was to develop a methodology for the diagnosis. And so, as I said, we used the WHO tools as a starting point, but quickly we moved to a comprehensive mixed methods approach, because the majority of tools are quantitative, they're checklist driven. And we could see instantly the shortcomings of this. Firstly, there was limited quantitative data available, but also just the shared sense of prioritization. And I think this is something that Fawzia alluded to. There are some champions in every facility, but on the whole, the facility staff did not see this as something they could do much about. And so, in fact, a mixed methods approach based on the checklists inspired by WHO guidance, but also qualitative work with health administrators, hospital staff, patient representative groups, and community leaders actually led us to quite a different diagnosis and assessment of what the priorities were. And for example, we came in with the notion that heat and food security would be the main preoccupation, which of course it was, but malaria was above all the preoccupation for hospital staff and the community. And so for many people, the climate crisis is mediated by its impact on malaria epidemiology. And so in fact, having a stable oxygen supply was a key priority for managing those complicated malaria cases. Likewise, reinforcing the blood bank. So it was seen as a critical resilience measure for that facility. So at the end, what we realized at the end of this process is that if we think about the WHO guidance, which puts the accent on mainly on infrastructure, energy, waste, and health workforce, we actually realized that in a system where hospitals are to some extent functioning in isolation, in that there are, in terms of the governance of the health system, it's a very resource-constrained system, and limited central initiatives filter down to hospital level. In such a system, we need to be thinking not only of those 4 infrastructural domains, but also the health programming itself, and also the leadership and governance and financing. So in the end, those other 2 aspects, health programming and leadership, governance, financing, became part of our model for health facility intervention in a setting where the link between facility and national level is weak. I think so. I think that the lessons for us was the need for this qualitative approach, which led us to quite different decisions. The need to integrate governance and health programming into your resilience and sustainability planning at facility level, but also that carrying out this process in this very combined collective way with the staff of the hospital and the local healthcare administration resulted in a real change in the atmosphere and the ambience in that hospital, and for the first time a sense of leadership, of empowerment amongst the hospital staff. We've seen other initiatives starting since then. So whilst on the one hand, at the end of this process, we've carried out the prioritization exercise with the hospital staff. We've made a roadmap together with Alima based on 21 high priority solutions, which we're now in the process of starting to implement. But in addition to that, we're seeing other initiatives emerging at hospital level, which has been quite inspiring to watch. So I think from here on, as well as accompanying the hospital through that full process of implementation, and as well as starting to work with other healthcare structures, for example, we're now developing a collaboration with Stellenbosch University to look at expanding this model to primary healthcare facilities in Western Cape province. We want to return now to our colleagues in WHO who developed the checklists and start to work with them to see, actually, can we now establish an approach to operationalizing this? Can we build on this experience to develop the toolkit for making this happen at facility level? And could there be a bankable commodity or something that actually we can work with donors on? Because until now, the lack of resourcing for these sorts of initiatives in low-income settings is of course the biggest barrier. And if we can develop these toolkits and some sort of package that appeals to funders, that might start to change the situation. Thank you.
Great, thank you very much for highlighting some ideas, but also really reminding us that this is, climate change and sustainability are a lens through which we can look at health system strengthening and transformation, and how important it is to bring everybody with you on that journey. A sort of message of hope coming out there. Thank you so much. I'd like to turn to Aditya Gurundati, who's head of ESG and Sustainability Operations at Dr. Reddy's Laboratories. I hope you're online and that we will be able to hear you.
Yes, I am.
That's great. Thank you so much. We know that you've been working on.
Sorry, hello. I'm not able to hear you.
Are you finding it difficult to hear me?
Yeah, I lost like 10 seconds.
You maybe we can just try and make sure that you can hear me. If you could sort of do a hand signal to highlight that maybe you can hear me. Would that be useful? Can you? Yes, perfect. Thank you so much. We're really interested in the pharmaceutical industry in this space because medicines contribute so much to the carbon footprint of healthcare around the world. And it's something that we can all do something about, not just in the production, but maybe also in the prescribing and the utilization of medicines. It would be great if you could tell us a little bit more about what you've been doing and what your lessons learned are, so that we can take those into our panel today.
Okay, thank you, Sonia. Thank you for introducing me, and thank you for asking us on the panel. So, for the people who don't know us, we are Dr. Reddy's Laboratories. We are in the business of global generics and biosimilars. So essentially, we make the medicines whose patents are about to expire or expired, and then we try to make affordable healthcare as much as possible. The tagline for us is "Good health can't wait." We want to provide the best healthcare facilities or the best health to the maximum amount of patients around the world, and that's how our business model has been. It's about reaching the maximum amount of people as much as possible. And yeah, as you rightly said, healthcare as an industry, if you take a step back and look at the industry, it's essentially a service industry. And as it is with any service industry, much of the emissions are scope 3 emissions, are the emissions of the medical devices manufacturers, pharmaceutical devices, pharma and allied medicines, injectables, and so on and so forth. And even from a waste perspective, or even from a global overusage perspective, also pharma actually takes a bigger chunk. Around 16% of the injectables in the world is getting wasted because due to hundreds of reasons: cold supply chain, due to expiry, due to not reaching the patient at the right time, due to reaching late. There are hundreds of reasons for which there's a huge amount of wastage, and that wastage is also contributing to a huge amount of our emissions. If I look at my emission roadmap, my own emissions pie, then Dr. Reddy is around 10%, 10 to 15% is within the fence, and around 85 to 90% is again outside the fence, both value chain, upstream and downstream.
In which aspect? You can't hear me.
I just heard the word.
I just wanted to ask you to repeat those numbers again, because they sounded important and I didn't quite catch them. The numbers of your carbon footprint. You said 10 to 15% is in? It is within the fence, scope 1.
And scope 3 is around 80% plus. So when
over
I say
80% is scope 3. Thank you. Sorry, keep going.
Yeah, I think my sound is coming and going. Somebody has put up a request. I'll be a bit more mindful. Please let me know if I'm not audible, or if the words are not coming out right.
We can hear you, Aditya, but it would be helpful because of the sound if you can speak a little bit more slowly and a little bit more loudly. I think it would help me follow anyway.
Okay. Sorry. So hopefully this is better. I'll try and put better intonations. Going back to my English 101. And so yeah, as I was saying, a huge chunk of the emissions from pharma industry, if I look at pharma singular company, let us say Dr. Reddy's, or let us say Novartis. I work with Novartis also. I worked with GSK for some time. So there also we see that a huge amount of emissions are both upstream and downstream. So Dr. Reddy's is downstream to Novartis in many senses, in many therapeutic areas, where much of their emissions are with me, and much of my emissions are with my suppliers. And as we go down to the nth supplier, the last person, there the decarbonization initiatives are not yet started, or just about to get started. And there's a huge amount of potential which needs to be unlocked. A lot of low-hanging fruits which Novartis did a decade back, which Dr. Reddy's is doing today, or must have done 5 years back, still haven't been going to the suppliers at the end of the value chain. And there we need a huge amount of impact. When it comes to Dr. Reddy's, to us, we have got 14 ESG goals which we had taken. A good chunk of the goals were around climate neutrality. We are planning to become climate neutral by 2030. We are also working on value chain decarbonization, but we also have goals on accessibility and affordability. I was hearing somebody say about accessibility. Accessibility versus climate risk is one thing which a pharma as an industry is getting pulled. Actually, pharma is getting pulled in multiple directions. On one side, we say about affordability of the medicine. while on the other side, we talk about climate resilience. Climate resilience, as we all know, it will take some amount of capital expenditure to be put actually into the pharma, onto the shop floor. The returns are there. I do understand every good decarbonization project would have a return of around 3 to 5 years, and I can vouch for that. But until that 3 to 5 years, the accessibility or affordability would sometimes take a backseat. And from an overall, when we look from an overall pharma perspective, accessibility and affordability are number 1 and 2 priorities for us. And rest of the things we need to work on along with them. And hence the challenge with pharma as a whole is that one side we are talking about accessibility, increasing the medicines availability. On the other side, we are talking about medicine wastage and AMR. Medicine overdose and AMR is also a very, very real problem. And with increasing climate risk, with increasing exposure to adverse weather events, or maybe even in any superbugs which are coming out, AMR is a very, very real threat which is there on the radar. It's actually one of the top 10 threats as we talk about. So at the end, my submission is from a pharma value of view, pharma is getting pulled out into multiple directions, and it is very, very crucial that everybody, including the healthcare facilities, work together to solve this problem as a whole. Single company or a single sect in the value chain solving it for themselves would actually just exaggerate.
Thank you so much. So you're reminding us that we have to all do this together, that you have a supply chain as well. Everybody has their own supply chain of a supply chain. And if I've understood it, that really there's some issues around affordability and accessibility to make sure that not only do we make it possible for people to have the medicines that they require, but that we have managed to do that in the best way possible in different parts of the world. And of course, there's the decarbonization piece, but then there's also the resilience building, making sure that actually the products that are manufactured and delivered can keep doing so through difficult circumstances. So thank you so much. So now I'd like to turn to Vincent Bretin. Thank you very much for joining us. You're Director of Results and responsible for the climate roadmap at UnitAid. And I know that you've been working with UnitAid for a while. And maybe you could tell us a little bit more about what you've been doing and what this roadmap looks like and what you're looking for to transform this world.
Thank you so much, Sonia, and thank you so much for the opportunity to join the panel and so many inspiring speakers and organizations here. So I'll give you 3 key messages, I guess. One is, first, what we've learned in the last few years, trying to understand what it means for an organization like us, international funder working on access to healthcare and health innovations in low and middle income countries, to look at climate. And the first message is around the fact that climate touches pretty much everything we do and pushes us to rethink our business, essentially. The second message that I'll get to is, how do we guide our work as an organization working on products? And I'll talk about climate smart health products, which we feel could be our North Star in this space. And finally, I want to touch briefly on the importance of what we call doing our part, which is to do our fair share of emission reductions. But first, in terms of the lessons that we learn. Over the last few years, we've incubated progressively more and more work around this area, doing our own footprint as a starting point. But now looking at 10 specific products, and you've talked about baseline and data, I think that's so important. And we really wanted to understand, okay, we have a number of important products that we support in terms of introduction, in terms of access in many, many countries. HIV treatments, malaria treatments, diagnostics, across multiple disease, maternal health, oxygen, and so on. We've taken 10 of those key products and assessed not only their carbon footprint and the entire life cycle to understand the source of emission, but also environmental footprint of those products, and also the vulnerabilities in terms of climate. And learned a number of important things which will be published very soon. But for instance, the fact that the footprint of those products is in the order cumulatively of millions of tons of CO2. And those of you who are used to emissions, will see that this is a very significant number. This is the equivalent of a pharmaceutical company, essentially, as a whole. We've seen as well that there is significant pollution from other sources of pollution and impacts on nature beyond carbon and greenhouse gases emissions. Take bed nets as an example, and many of you would know that bed nets is a key tool in the fight against malaria. There's about 200 million bed nets being distributed every year. That's more than 100,000 tons of plastic waste generated every year. And right now, there is almost no recycling mechanism in place anywhere to deal with that. We've just heard from Dr. Reddy, colleague, and the fact that the pharmaceutical industry is also, very much concerned about the potential pollution around manufacturing sites, and we know that's a potential area of concern. We've learned as well that there are issues around resilience. Some products may not be resilient to extreme heat, for instance. Some products are produced in very concentrated regions in the world that are exposed to climate hazards. And distribution in general of those products is very sensitive to climate hazards in low and middle income countries. So when you take all of this together, when you look at also not only climate sensitive disease, but the fact that the communities, the people that are impacted by climate change are the exact same communities that don't have access to health today. And so the communities that we're trying to support with our work actually see their reality changing because of climate change. So that led us to this conclusion, okay, climate is not something that is just for this part of our work, this disease or this aspect. It's fully encompassing, it's about mitigation and adaptation. It's also about the environment, and it has to be a holistic approach. So that's message number one. Number two, it's of course very big when you start looking at this. And what do you do as an organization that has its own business model, its own comparative advantage, its own strengths, but also limitations? And we felt that because we work on products, what could guide our work is what we call climate smart health products. Something that is almost like a scorecard, something you would look at for any kind of health products to say, okay, first of all, is this product not harmful to the climate and to the environment, with a number of things that you would look at within that. Secondly, is it manufactured? Is it distributed in a way that is resilient to potential climate hazards? Third, is it responsive to the way disease and populations are being impacted by climate change? For instance, are we designing products for specific use cases like displaced populations? And maybe we have a good solution for urban settings, rural settings, but not for displaced populations. And we need to rethink not only products, we're a small organization, 100 people based in Geneva, but that's nevertheless important to do. And we're working towards a minus 50% target by 2030, but also our portfolio of investment. We have $1.5 billion of active investments, more than 40 implementing partners. We want to embark all of those partners on a decarbonization journey. It's going to take time. It's going to have to be progressive, but with the support of the Climate Action Accelerator, I think we can make a lot of progress in the coming years. Thank you.
Thank you so much for that vision and for highlighting how important it is to really start shaping things. I'm going to ask you the next question directly, but as I come around the panel a second time, I'd like you really to think in the way you answer this question a little bit about what is that extra thing or acceleration that we need to take something to the next level. So we're not just tracking on the bit by bit, but what is it that will help us really take it to the next level? And I know you're looking at how you can try and shape the market. And I was wondering if you could help give us some sense of what that might look like in terms of innovation procurement or other ways of doing things.
Sure. And maybe I'll start by saying that we need climate smart health products, but we need, first of all, health products that have health value and that deliver, the access and the quality care that we seek. And where we come from, we've been working for more than 70 years on shaping markets for low and middle income countries. That means pulling a range of levers, whether it's procurement levers, regulatory levers, working with manufacturers to change the market conditions and create the conditions that will incentivize the types of products that we need, the types of affordability that we need, the quality of products, the supply diversity, the supply quantities that we need. And we've done not just United, but collectively magic, with manufacturers, with partners. When we see, that right now you can treat someone living with HIV for $45 a year. the entire year of treatment. And that's coming from obviously a very different situation 20 years ago, that you have pediatric formulations and the likes. And so everything that we've been doing in service of those health objectives, we feel those same types of levers by working through regulation, by working on procurement, by working on incentives, by working with manufacturers, by creating demand, by creating new standards, can be used to shape those markets and create those new expectations, those new incentives, and progressively move towards those climate smart health products. It has to be in partnership, and I think it has been said before. It cannot be just us alone, it cannot be manufacturers alone. I think we need the entire system to push in the same direction. That's why some frameworks, some priorities, common definitions, common goals will be so important. And also each organization playing to their strengths and being able to contribute from where they are.
So we're all part of the same jigsaw puzzle, and we all need to push harder. I mean, I think shaping markets is incredibly important, and the innovation that needs to take place there, or the drive to keep knowing what you need to push for, is incredibly important. I'm going to turn back to you, Aditya, because you're obviously in the pharmaceutical industry. You're supplying us. You've got your roadmap. You know what you're doing. But what do you want from the people who buy products from you to support you? We don't often ask the question that way. What healthcare providers who buy your products? Do you need anything?
I think what we need is we talk about decarbonization. Let us not just talk about decarbonization. We can talk about the overall environment impact. We can make a therapeutic line carbon neutral. But at the same time, can we also make it affordable? Can we also reduce its toxicity? I do understand this is a forum where we are talking about decarbonization journey, but then decarbonization is not the only big elephant in the room. There are other things also which we need to talk about. Secondly, when we talk about supply chains, when we talk about a pharma supply chain reaching out to the hospital or any healthcare facility, the most important things are the CFAs and the distributors from whom the secondary and the tertiary supply chains work. Those have to be made more robust. That's not within us to do it. So once it leaves our CFAs, carrying and forwarding agencies and distributors, post that the resilience has to be developed. So as I said, much of the emissions are with value chains, upstream and downstream. So the downstream partners have to work together.
So we really need to see this more holistically. It's not just tracking carbon. It's about a wider range of things, and then the resilience across the supply chain, and how we, I guess, as buyers of products or prescribers of products, we need to understand that more effectively. So thank you very much for that. Fawzia, you're big buyers. you're prescribing and looking at this differently. How do you take the holistic approach to this and use it as your vision to drive change across the whole of the supply chain and through the behavior of your health professionals as well?
So I'm going to sort of not just relate this to what we do, but tell you that what we do is informed by the thinking and collaborations with the NHS and their leadership in this area, as well as some thinking with the Lancet Sustainable Healthcare Commission that I'm on, and our discussions around what should be done. And clearly, first of all, I'm glad that you've included a colleague from Reddy's. Great to hear what I understood of what you said. And particularly, I have to say, I was really encouraged by your approach of looking at, because you can, at the life cycle assessments of some of the products, and then looking at this more holistic from that point of view, because that's very rarely done or possible. And the environmental aspect that comes up with it. So there's the products, there's the packaging, which is a really big part of this. And if I could just put a plug out, we know that we can do blister. We don't need blister packs for most things at all. And that's a really big part of the problem in terms of the environmental footprint, just directly around the products, but then it's all the downstream, the additional packaging as well. So much can be done. So I'm hoping that the likes of Reddy's will be able to really look at that, because what we're trying to do, back to your question, is, first of all, we're adopting the same targets as the NHS and suggesting to governments that we're providing orientation to, that they do the same, to be able to send the same market signals to help suppliers, and so that there's consistent direction on where they should move. And we are asking them to disclose first their scopes 1 and 2, but even better, third, and to make public their net zero commitments. And so obviously we would be preferentially purchasing from those with the most ambitious targets. And we're also negotiating on packaging, and so that there are take-back schemes for plastics in particular. And to send the signal, we don't want them, and we want you to change because you're the best, you're producing them, you're making the choice, we're not, and you should take the burden of it. But the other sort of broader thing in terms of operations and people who make the decisions to buy, because there's several who make the decision before it comes to the procurement officer who negotiates with the suppliers, is that we're having a discourse around, is it necessary? And this is not just a, refuse, reuse, recycle discussion. It's a bit more than that. Overprescribing? Are we overdiagnosing? Have we moved away from evidence-based medicine? And moving the discourse to primary healthcare, because that's a much better bang for your buck if you keep people healthy and if you keep them away from the health system altogether. So those are the kinds of discussions we're having, in addition to examining practice, because increasing in LMICs, higher standards are associated with higher use of single-use items, more products, the better, the physician, the better, there's a lot of perceptions that go along with this that need re-education of health professionals, but also customers. And so basically, the whole discourse around keeping people healthy, what it takes, but also we're learning that in low resource countries, there are many procedures that, moved in that direction of high-end, intensive, irrational use of products. They're still conserving or sterilizing or being much more prudent in terms of when they move from symptom management to a wait and see to a diagnosis to treatment. And some of this is providing indications of what northern entities might do. So bringing them together, and so cataracts, we know 30 times more waste in the West than in lower resource countries, and things like that. Just comparing notes will teach us a lot. So we're encouraging that too. Sorry, I took so long.
No, thank you so much. So, prevention is absolutely key. We know that the most sustainable healthcare facility is the one that doesn't exist because it's not needed. And I really appreciate your comment on not over-medicalizing everything. We have got a very quite a high intense medicalization approach in some parts of the world, which is just unhelpful to this agenda. But Kieran, you're a doctor, you prescribe medicines on a regular basis, I presume. How much do you take this into your practice, into account in your practice? And how do you think we really not just send a signal to suppliers, but also embrace this as healthcare professionals, and I'm counting myself as one of them, into our behavior change? And what do you think is needed for that?
So,
question, sorry.
Yeah, that is a difficult question because yes, I do prescribe, but just 1 day a week. So I'll just preface that because most of my work is in the humanitarian sector. Nevertheless, I guess where there's a point in common, it's about vision and a sense of agency and behavioral change. I would say that one thing I could draw in common between health structures in the NHS where I work and health structures in extremely resource limited settings with which we're working with CAA is in both cases there's that need for at the facility level for for leadership and for vision from hospital leadership or health facility leadership. I think that especially in very low resource settings where that, as I said, the central health system leadership will not necessarily impact at facility level because those facilities may be reaching out more to local partners, local NGOs, international NGOs to support their work. it's critical that that vision is built up at the level of the hospital and then, or the health facility, and then partners, the facility can reach out to partners, or they may already have existing partners for support to develop plans, transitional plans for making their work more environmentally sustainable and resilient. Yes, that applies to prescribing, to use of medications, but it also applies to other aspects of health facility management, including one thing we saw in Chad particularly is emergency preparedness and disaster management committees or hygiene committees at the hospital level. These are interventions that need not be costly, but could lead to a much better use of certain resources, or minimization of certain consumables at the facility level. So I think that it's important to, even in very resource limited settings, not to neglect the behavioral change elements, as I said earlier, the health programming elements, because until we can define best buys, and I think this is where I would want to share our experience with the Attach Alliance, the WHO Alliance on climate resilient, environmentally sustainable healthcare. And because I think collectively as a community of practice, we can start to define those best buys, both the high impact interventions that are more costly, but also the relatively high impact interventions that are less costly. And I think that's where the behavioral change element has to come together with all the infrastructural elements that are currently the main focus of discussion.
Thank you so much. I'm going to come back to you, Jemilah, to ask you about how this plays out in Asia. But we haven't talked. We've talked a little bit about customers, a little bit about the community, not so much about the role of patients in all of this. So I don't know whether you would like to try and bring that into your answer, and maybe we'll try and keep it brief, because I'd like to bring the audience in as well. Have we still got you there, Dr. Jemilah?
Yeah. Yes. Now, I've been listening to the wonderful remarks made by the panel, and I want to come back to one point, and maybe that touches on the patients as well. What are we doing as a health community to raise awareness on the linkages between climate and health? Now, we are probably, healthcare workers are probably the most trusted people on the planet, and yet we are not raising our voice enough. I mean, you can't compare, NHS is so much more advanced than many health systems in the world. But the problem is that we won't change unless health workers start to change. And that requires fundamentally some shifts. I really like the point that I think Fawzia made about data. At the end of the day, if you want to shift things, you've got to have the data. And politicians will listen to data, particularly when it involves finances. Now, a group of, you may be aware, the Canadian medical sort of fraternity came together and said, all right, we need to have a shift in how we teach medicine, that climate and health is not even in curriculum. I think globally, the figure is something like 15%. So how do you expect patients to even know about this when the doctors don't even talk about it, or may not even know or be aware of their responsibility as well? Simple things like prescribing inhalers. The different types of inhalers have a fundamental impact on methane gas, greenhouse gas emissions. So I go back to system shifts. I think, I do believe that all the initiatives that we do are really important, but fundamentally we need a system shift. We need to really look at that. And I want to highlight one point that is, in front of us very soon. We have COP28. If you look at the health declaration in COP28, there's not a single mention on why it's so important for healthcare, the health fraternity, to raise their voice on the need for us to push fossil fuels to reduce the emissions and to call for a rapid and just transition. It's not even there. So, I'm in despair sometimes, because if the body that is representing us is not pushing this hard enough, in these fundamental declarations that are intergovernmental, then we are losing that opportunity. And I think we need to raise our voice.
The trusted voice of clinicians in this space is hugely important, and I think others have alluded to that. I would like to open up to anybody in the audience who wants to ask a question, or two or three, but maybe just to make it easier for me, you could just stand up if you're wanting to ask a question, and then we'll do a quick round and answer. It does mean you'll have to show yourself if you want to ask a question. Otherwise, I've got plenty, so don't worry. Yes, just okay, we've got one here and one over there. Maybe we could go here and then take the second question there. And maybe if there's another one or two in the audience, we could take them in the round so that we use our time effectively. Thank you.
There's two questions from our audience online. So the first one from May from DNDI, Drugs for Neglected Disease Initiative. The question is for Aditya. You mentioned that for pharma and DRL, affordability and accessibility are priority 1 and 2. It wasn't clear to me how reducing waste and investing to reduce pharma emission impacts affordability and accessibility of the pharma's medicine. Thank you.
The other one.
The other one is from Laura. It's not addressed. Dengue has the potential to impact on up to 4 billion people, given climate change and with this climate-sensitive disease. There has been a huge push to tackle malaria, but what are the organizations doing or recommend us to do regarding adaptation to climate-sensitive diseases, sometimes where urgent innovation is still much needed? Thank you.
Thank you so much. And we've got another question here.
Hi, good afternoon. This is Daniela Marco. My question is for any of you who want to reply to this, is about longevity of our population, because we are aging, and I would like to know your take on preventive medicine instead of good quality of life versus just length of life. So if you can develop a bit more on this idea on maybe preventive medicine can also reduce emissions, because there will be less pharmaceuticals products to produce and treatments to provide. So yeah.
Thank you so much for those questions. I might turn to you, Jemilah, first, and then to Aditya, and then ask our panel here if they want to come in. And just a word of warning to our panelists. Before we leave everybody today, we'll have a parting message from each of you. So do be thinking about what you would like to leave as your last message. But over to you, Jemilah.
Yeah, I think that's the question around diseases that are climate sensitive is a very important one. For us in Asia, we live with dengue, right? It's endemic, but we are seeing increasing numbers in North America and so forth. I think this is where collaboration is going to be very, very important. How we're even educating doctors is, I come back to education, because I think it's fundamental that if you are not teaching climate and health, then one of my friends who got dengue in North America was undiagnosed for some time because nobody would think about it. So I think fundamentally things have to change. Now on longevity, I think we're talking about quality and of life rather than quantity of life. But I think we have to face the fact that people will live longer, except that the last Human Development Report surprisingly showed that the life expectancy actually declined in the last 2 years. So go back to a focus on wellness rather than managing illness. Go back to the fundamentals of good primary healthcare and preventive care, but not forgetting to incorporate the importance of climate, the linkages to climate and health. I think that's how we need to approach healthcare in this century.
We tackle both emerging diseases and try and focus on wellness. I would just like to make sure that we answer the question about the affordability elements that was asked for Aditya. Are you still there? Would you like to respond to that question?
Yeah, I'm still there. I kind of answered to her on the private chat, but just for the benefit of everyone. It was a simple equation. On one side, pharma, specifically global generics, is getting pushed more towards affordability of the medicines. On the other side, there is price erosion. Just for taking our example, we have had around 75% price erosion on many therapeutic lines. And on the flip side of it, now we are talking about advanced decarbonization journey. Low-hanging fruits for majority of the major pharma industries are getting used up. Now, let us say I talk about advanced decarbonization solutions like supply chain decarbonization or waste heat recoveries. Those require huge amount of investments. I cannot go to my suppliers and ask them to provide me something at a lower cost and at a lower carbon. At one instant, it will take some time for them to adjust to that. There should be some amount of long-term. And that was my point. That was the point I was leaving.
Thank you. And we do have examples where things are low carbon and low cost and better for health, where there are win-win-wins. And we do need to highlight those sweet spots as well. So your Fawzia, then Kieran, then Vincent.
So just to comment on, when we talk about going back to primary healthcare, or we talk about re-emphasizing the health promotion, disease prevention debate and longevity, etc., I'd like to say that yes, we need to go back to the principles, but we can go forward. By that, I mean is that we're not going back in terms of some regressive model. Actually, we're learning an awful lot about things like green prescribing, or that, social prescribing to prevent loneliness is actually, does as much in terms of reversing morbidity and mortality than, as equates to smoking in terms of, I'm saying this wrong, but you get my drift. Playing music in old age pension homes, apparently 12% reduction in medication. I mean, this is new research, but that is informing and should be informing our decisions of whether or not we prescribe and how we do business. Unfortunately, most of our research in healthcare that's providing the evidence is, there's a conflict of interest in terms of who's funding it. So we're going to have to sort of really purposefully look at the data that is driving our practice and try and do some reimagining healthcare in the process. Thank you.
Kieran.
Thanks, Fawzia. So just to address the question on vector-borne disease and to touch on the prevention issue, this is clearly where we see population level resilience and health facility resilience coming together, because if you focus more on preventative approaches and you have a healthier population, it reduces the demand on the health facility, and hence it means that you make better use of what scarce resources you have. To take the Chad example, out of the 51 solutions that were produced by that process we undertook, the vulnerability capacity assessment, more than half of them were health programming interventions. So less than half of them were infrastructural. And of those health programming interventions, it was bed nets, indoor residual spraying, seasonal malarial chemoprophylaxis, but also innovations on such as malaria vaccination. So these are the preoccupations of the health workforce and the community. These are preventative measures that would massively reduce demand on the healthcare facility. Yes, we need to operate, we need to implement these, and we need to try to measure the impact, because in such settings, it's still very difficult to get reliable data on cost effectiveness. And so to define these as best buys, we're not there yet. But the point is that, by thinking about population resilience, you are actually reducing your demand on the health facilities, and you're making your health facility more resilient.
Thank you.
Yeah, I just wanted to bounce on the question around affordability, accessibility, and what it means to go for decarbonization and keeping products affordable. It's a tension we're going to have to deal with as an organization and collectively. Clearly, the answer won't be straightforward. But I would say from the modeling we've done of lifecycle analysis and the specific products and the levers that were identified, we see across the 10 products that we've selected that 40 to 50% of the emissions could be abated at a neutral cost overall. So some investments, of course, will be needed, but the return on investment is such that in the end, you can do this without increasing the price in the long term. So that's encouraging. Of course, we need to do it in practice. So I guess I would say, let's see in a year or two from now, how much progress we can make. And I hope we have more examples like this one. I would flag as well the work of Medicines for All, which some of you might know. It's an organization that's focused on green chemistry. And they've, for instance, demonstrated that for some TB drugs, the number of steps involved in the chemical process can be reduced drastically. And that would lead to a reduction of the cost of production and of the emissions associated to the production. So there are some win-win situations out there.
Thank you. That's really reassuring to hear. So I'm going to ask for a closing round, but I would like to, as part of that consideration, just to think, are there some elements that we haven't considered, like the financing of health systems and the incentives that are provided to provide better health, or such elements that we need to take into consideration? I'm going to start with Vincent because he's next to me.
Sure. No, maybe a couple of thoughts. One is, what are some of the key ingredients of success here? I think we've talked about partnership extensively. You've just mentioned financing, and yes, I think that's important to have that in mind. We won't be able to do all of that, everything that's been described without the financing to do it. The last one I would add is learning. And we are somewhat new in this space. Some of you have decades of experience, but we feel that we individually, collectively can learn a lot, and we'll need to learn a lot and be open to see what comes out of the first steps we're going to take, the first initiatives, the first projects, and what we can learn from what has been done, in the cases where you've been involved for many, many years, and we can build on that.
Thank you. I'm going to ask Aditya and then Jemilah and then go to Kieran and Fawzia. And I'm sorry, I'm losing my voice. Parting message.
From our side, from the farmer side, for collaboration, pharma and healthcare are not two separate industries, and the decarbonization journey or any kind of an environment or social journeys would have to be together, and we have to work together. So we have to just collaborate and see where the lacunas are, where are the places where we can collaborate more, specifically on cold supply chains, on last mile availability and last mile affordability of the medicines. Those are the places where there's a lot of work that needs to be done. And that is the place where we need to collaborate together, to work together on those, because we don't have absolute visibility on those, and neither does the healthcare.
Much so, a lesson of learning, a lesson of collaboration. Jemilah, what's your lesson?
I think we are at a tipping point. I think we're at a point where we have, so much knowledge, innovation, and so I feel that the sense of possibility is there. What we need to do is use our voice well. We have a very significant role as healthcare professionals to drive this agenda, because no one else is better placed to do it. And I do feel, ultimately it's about systems and it's about finance.
Thank you. Systems, finance, and using our voice. Kieran.
I would say that in very low resource health systems, where in fact emissions will still need to increase before they start to go down, in that there's a need to expand universal health coverage in the first instance. I think we're still at the stage we need workable models and tools to make this, these changes happen at the level of facilities. And we need communities of practice, which we do start to have, to help to define what are the best buys at facility level. And then in terms of donors, please fund implementation research in these settings, and also tell us, what is what do you need? What is the sort of package that you need us to define, or is it a checklist, or what, to be able to actually take the risk of funding this work in very low resource settings, and especially fragile settings? Because I think that we can work on the implementation tools, but we need to know what is actually going to make donors want to invest in these settings.
So getting the donors on the hook. Thank you.
So I'd echo Jemilah's statement in terms of our agency, because that's we don't have time to reimagine, remodel health systems. We have an immediate crisis that we need to use our leverage in terms of making the changes. But for me, benchmarking is the key, because that provides you with the education, not just for your own sector, but in terms of what to lobby for wider. But if we were wanting to reimagine our health sector, which we sorely need, I'd say the key thing is we have to find a way in which it pays health workers to keep people healthy. That's the simplest way I can summarize the problem.
Yes, thank you. Getting the right incentive. There's a huge paradigm shift about what we're trying to do here and whether we're paying people to treat sickness or paying people to be healthy. I'd like to thank our panel. I hope you'll join me in thanking Jemilah in Malaysia, Aditya in India, Fawzia, Kiran and Vincent here. Thank you so much. We've got a break now, and please come back because the next session is on shifting paradigms. And I think that's exactly what we're touching on here, is how do you actually take this to the next level and start shifting our paradigms about health systems and how we really incentivize real change. So thank you, everyone. Thank you.
Thank you. Thank you.